classification is still the same. That's halogenated. The gases, the halogenated and non-halogenated, which is mainly nitrous oxide, then parental many forms. So let's start with the gases. The rationale is still the same: provide hypnosis, analgesia, muscle relaxation, and then to reduce the visceral reflex responses. Now, nitrous oxide, if it is used, the key issue here is that it is, the main issue for nitrous oxide is that it's effective as an analgesic, and also very safe, fairly safe, with rapid onset and recovery. So mainly, it's mainly used as adjunct to other and adverse effect. In terms of the halogenated, the halogens, here is where I want us to go through. Would be very, very specific in terms of therapeutics. You have to go through each of them and know the adverse effects and the drug-drug interactions. So if we start with the halothane, the key issues is hepatotoxicity. The other issue is malignant hypothermia, and it can cause myocardial depression as well. Now, in terms of malignant hypothermia, it is significant, especially if it's used in patients with the pheochromocytoma, who already have high levels of epinephrine and norepinephrine and pre-existing cardiac disease, and therefore it can be fatal. Now, I would like to ask a question at this point. So, if a patient develops malignant hypothermia associated with halogenated anesthetic, in this case halothane or any other, how will it be managed? How can we manage it?
Using dantrolene.
Yes. So this is where we use dantrolene is a key. So I would be interested here in drug-drug interactions. Say if a patient is using a drug that can cause hepatotoxicity, etc., you've got to remember that in terms of therapeutics. With regard to isoflurane, the key issue here, again, it can cause malignant hypothermia. That doesn't mean that it is contraindicated. It is not, because maybe we would not have any other option. So you have to, if it develops, that's why now you have to use dantrolene to counter that. The other issue for but it's fairly safe about hepatic issues and renal toxicity compared to halothane. And fluorine issue here is seizure disorders. So if patients have avoided as much as possible, it can also cause malignant hypothermia. Desflurane, this drug causes laryngospasm and coughing Of course, this is during surgery, you would want to avoid this as much as possible. So you've got to remember these adverse effects. Are there any questions on halogenated drug? So the key here is, as long as you can Am I audible?
Yes, you're now back.
Yeah, but I think I'm at the office and I think we have a lot of internet issues today with the university line. Let me see. Kyoko, I'm disabled, please. I need to share. Oh, this is very frustrating.
Yeah, you can share now.
Okay. Okay, you need to inform me if I go out. Is the screen visible now?
Yes.
Okay, thank you. Okay, so are there any questions up to this point? Okay, let's move on to parental agents. So here we have barbiturates, we have benzodiazepines, we have opioids, we have ketamine, propofol, which somebody had mentioned, etomidate, and then combinations basically for balanced anesthesia. So if we start with the thiopentol, it's no longer used very much nowadays, but basically thiopentol has rapid inductions and rapid recovery. The key for rapid induction is that thiopentol is one of the most, one of the drugs that is highly lipid soluble. So it is distributed within seconds. it can enter the brain within a few seconds. The recovery is fast as well. Unfortunately, being a barbiturate, there are respiratory issues like laryngospasm, bronchospasm, and histamine release. Now, at this point, I want to ask a question. What happens to if there is massive release of histamine? What happens to the blood pressure? Does it go up or does it go down? Can I
think
pick
the pressure will
somebody?
go down.
It will go down, okay? So that's very important during surgery. So the release of histamine, and we will go to Propofol. I was asking that question because somebody had asked a question about Propofol earlier. So the release of histamine may lower the blood pressure and may cause hypotension, which could lead to, so the other issue is respiratory depression. Although there is limited cardiovascular effects, but depending on how much histamine is released, it may lower the blood pressure. Then, of course, the other we discussed earlier with the barbiturates for patients who have predisposition to porphyria. So that's a major issue. Now, with regard to benzodiazepines, these are also widely used drugs, especially for balanced anesthesia. Now, I'd like to ask a question. What is balanced anesthesia? What do we mean by the use of benzodiazepines for balanced anesthesia? Can somebody give it a guess? So what we mean here is when you use benzodiazepines, all these drugs tend to have like similar adverse effects. So you would tend to reduce the amount of the other anesthetic, and because of the adverse effect profile associated with the benzodiazepines, it will tend to balance off the other adverse effects and also reduced dosage. So this, there you go. So this balanced anesthesia, including opioids, muscle relaxants, because benzodiazepine has a wide spectrum. It can cause muscle relaxation. It can cause some other effects like opioids and other effects like the other accompanying drugs. But importantly, they can also be used alone for minor procedures like endoscopy, etc. When it comes to opioids, we did mention that we may use morphine, but ordinarily we do not want to use morphine because of majorly respiratory depression, which can be fatal. And therefore, we would tend to use other drugs like fentanyl, sulfentanyl, alfentanyl, remifentanil, etc., which have dual effects. Number one is they have less respiratory depression, and number two is they are more potent compared to morphine, as some of them may be even up to 100 times more potent than morphine. Or let's say up to more than 10, 20 times more potent than morphine. So there you go, the fentanyl group. So they have They cause respiratory depression, but less. Respiratory depression cause less amnesia and less likely to interfere with hemodynamics. And therefore, they generally are preferred, including cardiovascular effects. So basically, fentanyl is combined with other agents, but the major adverse effect is rigidity. Alfentanil and sulfentanil are basically more potent. They're more potent and produce analgesia. So they're more potent than morphine, and remifentanil the same. So what I'd like you to do during your revision, kindly go through the stated adverse effects for each of these drugs. I think the latest is remifentanil. I think there is a new one. So go through all of them and the major adverse effects that have been, apart from what we have stated, the general adverse effects, specific adverse effect that is associated with each of these agents. With regards to Propofol, now Propofol is basically very much like thiopentol. It's a CNS depressant that acts on GABA receptors and also inhibits NMDA receptors, which is basically glutamate aspartate. So basically, generally depresses the CNS. As you know, glutamate and aspartate tend to stimulate the CNS function. Rapid onset of action, just like thiopentol, with rapid recovery. These are other properties of Propofol. It also has anti-inflammatory properties and is a bronchodilator, and that is unlike the barbiturates. And therefore, with these properties, it's now used for management of like head injury in epilepsy, in patients with asthma and related patients. Now, I'd like to make a comment at this point. These three drugs, Propofol, ketamine, and etomidate. These drugs may be used interchangeably. But in terms of therapeutics, I would like you to look at mainly the adverse effect profiles of each of them, because that may lead to selection. In other words, what kind of patient would I use for, say, etomidate? Which kind of patient would I use for ketamine, and maybe for Propofol? So these are the properties of Propofol, but these are the adverse effects. In other words, there is no much stability, cardiovascular. There is also injection, that's not a major issue, or apnea. But the main adverse effect is that it can cause tachycardias, or it can reduce the heart rate, and it can interfere with the blood pressure. And therefore, you would not probably want to use Propofol with a patient with, say, a cardiovascular disorder. So that's how we would like us to look at it in terms of therapeutics and the choice of drug. There was somebody with a question on Propofol. Yeah. Who was
Prof,
it?
yes, it was me.
Who answered your question?
Yes, yes, I am satisfied. Asante.
Okay. Now let's go to ketamine. Ketamine is a widely used drug for a very, very long time. It's a very good drug, especially for ambulatory patients. And now the problem with the ketamine is that recovery is slower, which may not be very significant. It's a cardiovascular stimulant, increases intracranial pressure. Now, the other major problem with ketamine, which has been a major issue, is that as the patient recovers, they tend to remember the bad dreams or hallucinations, what happened to them, and sometimes may lead to, it may lead to depression later, because patients tend to remember, the bad things that happen in their life. But then, the more important issues that I like you to remember about, apart from that, with ketamine, are these effects. Because during surgery, what you are really concerned with is recovery period, hemodynamic stability, cardiovascular effects, etc. So in this case, if it is a cardiovascular stimulant, and then of course you have to be careful with the choice of this drug if you are dealing with a patient with cardiovascular issues. It also increases intracranial pressure, and therefore, if you had a patient with a head injury, you would be more interested in using Propofol, okay, more than ketamine. So these are the therapeutic considerations for the choice of these three drugs, which tend to have the same effects. Now, finally, etomidate, again, it has the same, almost similar properties to barbiturates. Have in mind thiopental, in other words, fast effects, induction, etc. In terms of other properties, it maintains both cardiac output and diastolic pressure. And therefore, if a patient has cardiovascular issues, and then the choice, you tend to prefer to use etomidate more than ketamine or propofol. The other issue, but the adverse effects, so it could have, cardiovascular stability, but the adverse effects, these are some of the associated pain at the point of injection is not a major issue really. So these are the uses or indications either for induction or to supplement anesthesia, especially in patients with cardiovascular issues, because it has limited effects on cardiorespiratory systems. So if a patient has cardiorespiratory issues, then you may want to use etomidate. If a patient has a brain injury, etc., you may want to use propofol. If you are dealing with an ambulatory patient, then you may want to use ketamine. I think we'll stop there. Are there any questions? So the key issue is please, when during your revision, try to look at the properties of these three drugs. That is ketamine, etomidate, and propofol. Any questions? All right, in absence of any questions, I think we'll stop there for today. Yeah, go on.
Can
I
you
think there's a
explain
question here.
Can you explain the concept of balanced anesthesia?
Sorry?
Balanced anesthesia.
Yeah.
Can you
No.
kindly explain that one?
So what I was saying is, okay, when you are using anesthetic drugs, they are very okay. Let me go back. Sorry, it's like the internet is unstable. I hope you can hear me. Okay, let me go back. Okay, when you are using an anesthetic agent, these are the intended aims, okay? You want analgesia, you want muscle relaxation, you want hypnosis, and you want visceral responses. And more importantly, I think we are almost running out of time. You want to use lower doses, okay? Can you hear me? So are you seeing the rationale?
Yeah.
Yes.
You want to have all these effects, okay? You cannot use one drug to achieve all these at once, all right? You want to have hypnosis, you want to have, so what would you want to use for analgesia? You may want to use an opioid, isn't it? Muscle relaxation may be the same. You want to reduce visceral reflexes. Now, so when you use a benzodiazepine, it tends to have a little bit of all these effects, especially except analgesia, all right? Hypnosis, muscle relaxation, visceral reflexes. And so the net effect is you will use less of an opioid, less of an inhalational anesthetic, less of any other drug. So that way you are balancing, because the benzodiazepine would have all these effects, and then it would tend to balance the anesthesia. Have I answered your question?
Yeah.
So it would tend to have all these effects, and then you would want to reduce, and therefore it balances the anesthesia because of the properties of the benzodiazepines. In other words, you are combining A, B, C, D, and E, which are intended to have different effects. And then you have a drug that has a little bit of A, it has a little bit of B, it has a little bit of C, it has a little bit of D. So when you combine this drug that has all these, then you balance. Do you understand?
Yes.
I've answered your question.
Yes. Thank you.
You don't sound very convinced. Okay, you can still go to the literature and check. Another question?
Prof, maybe a quick one.
Yeah,
What does
go
it
on.
mean when you say ambulatory surgery settings?
What do you mean by ambulatory patients, if you say that? Is that what you're asking?
Okay, ambulatory, okay, means they're able to move or walk around. Now, ambulatory
So those
surgery.
are patients who can move or walk around, isn't it? And
Yes.
then there are bedridden patients or patients who are in coma. So that's the difference. In other words, you are not using for patients who are in coma. You're using for ambulatory patients, maybe for minor procedures, etc. That's what I mean. Okay?
Yes.
Have I answered your question?
Yes,
So
yes,
as opposed to say those patients who are comatose or who are very critically ill patients, that's what I meant.
Okay.
Okay, the last question, we still have 3 minutes. Okay, we'll stop there then. Okay, so class rep, are you starting your sessions with Dr. Busala tomorrow?
Yes, we are starting with him tomorrow at 9 or 8.
Okay, once you are through, then you can come back to me.
Okay.
You can inform me, and then we can be through with the anti-cancer agents as well.
Okay.
Drugs for lymphomas and leukemia. Leukemias, yeah.
I'm asking, can we do it concurrently? Because we only have one class with him in the morning, then we can do your session at noon, in the
I
afternoon.
think you just finish with them. Finish with the solid tumors first.
Okay.
Because I have some postgraduate classes as well to teach.
Okay.
All right, thanks.
Thank you.